Alright, hi guys, welcome along to another episode of YAC Yarns. My name's Chelsea, I'm the Deputy Chair of the CDHB Youth Advisory Council, and I've got my friend Tori, who you may now recognise, she's made a few appearances on YAC Yarns, who's also joining tonight. For those of you that are new, YAC Yarns is a conversation series that we're having for the CDHB Youth Advisory Council around health-related topics for young people, where we talk from professionals across the sector about these topics. Reminder that if you are watching the live stream right now, you can ask some questions. We've had a whole ton come through already, but if you have any extra questions, feel free to ask them on the live stream and we'll be keeping an eye on them. But I will introduce Joanna from Asthma and Respiratory Foundation New Zealand.
Good evening, everyone. Hi.
Thanks so much for being here tonight. We really appreciate it.
You're welcome. Lovely to be here.
We thought we'd just start off with letting you introduce a bit about yourself, who you are and what you do.
Right, well, as you know, my name is Joanna. I work for the Asthma and Respiratory Foundation New Zealand as the Research and Education Manager. For those of you who don't know, the Asthma and Respiratory Foundation is the not-for-profit charity sector organisation authority for all things respiratory, including asthma. We're made up of a scientific advisory board, and that advisory board contains leading experts, researchers, an authority on respiratory health service and delivery. We are responsible for writing the New Zealand best practice guidelines. So those are the guidelines which look something like this. Oh, wow. Which are written for the diagnosis and assessment and management of asthma in New Zealand. So those are written not just for prescribers and health professionals, but for the training and education of those health professionals as well. Yeah.
Wow, that's cool. It's really good. Like, it's interesting because you kind of may hear these like organisations' names and things, but it's interesting to hear actually what they do and a bit more about them. So that's really cool. We've had multiple questions come through tonight from young people, so we thought we'd kick off with probably the key question of what is asthma?
Yeah, well, asthma, as you probably know, affects the lungs. So it's a long-term condition that affects the small airways of the lungs. So specifically the bronchioles, the finer tubes of the lungs that are responsible for carrying the air in and out of the lungs. People with asthma tend to have very oversensitive airways. So unlike you and I who don't have asthma, their airways become oversensitive to certain triggers, and those triggers can exacerbate or cause an asthma flare. They cause the smooth muscle in those bronchioles to sort of tighten and contract, and it causes the lining in those bronchioles to become inflamed or swollen, and of course that then narrows the airways, which then causes the telltale symptoms that most of us probably know, and that is wheeze or tightness in the chest, or that sort of persistent cough and shortness of breath. So asthma it's a chronic long-term condition.
Yeah, wow.
So following on from that, how do you know if you have asthma? So how is it diagnosed?
You will generally there are 4 clinical symptoms that you will generally present with. So the most common is wheeze. That's sort of the most specific symptom of having asthma. You'll have coughing, and that cough can be worse in the morning or night. You'll have breathlessness, and you'll have chest tightness. So there's these 4 main symptoms, but it's not just having those clinical symptoms. In fact, if you just have 2 of those 4 clinical symptoms, that's a really good sort of start for a clinician to be thinking, that person is likely to have asthma. It may be that that person has a genetic tendency to have asthma, so they may have a parent who has asthma, or they may themselves have eczema or hay fever. So there tends to be both a genetic and an environmental component. Yeah. And then it's, even when you dig down deeper, there is also a characteristic pattern to those symptoms. So it's not just having the cough or the chest tightness or the breathlessness. It's actually looking at how those symptoms are portrayed. So having a nighttime cough or an early morning cough is quite common in asthma, or having asthma during the hay fever season, or at the same time that you have an upper respiratory tract infection like a cold or a flu. The symptoms can be intermittent, they can be seasonal, it could begin in early childhood. And so it's basically looking at those symptoms and that characteristic patterning of those symptoms that will lead a clinician to sort of coming up with a differential diagnosis.
I guess another question that kind of came through, is there different types of asthma, or is it just the one?
Yeah, that is such a good question. And I have to say, I probably haven't mentioned that by trade, I am actually a pharmacist, and I've had like 30 years working in community pharmacy. So I've seen a lot of asthma, and I've worked in a lot of sort of at-risk communities. And I think that we hear people, and you see definitely people in the sports field who have exercise-induced asthma, and that definitely is asthma, but we hear the common sort of variants that we hear are exercise-induced asthma, which is definitely precipitated by physical activity, and occupational asthma or adult onset asthma. So you may have someone that's never had asthma, and then as an adult, it just comes on all of a sudden. And that could be because they're exposed to an environmental trigger. It might be something that in their occupation or workplace, or it might be that perhaps that they have always had that underlying tendency, and there is a certain trigger in the environment that's sparked that. So you hear of people, they will relocate to a warmer climate, and they don't have any problems with their asthma, or they move to a colder climate with dry air, some more severe winters, and their asthma will trigger again. But generally, there are, we sort of, during COVID, you would hear people talking about, I have severe asthma, or I have mild asthma, or I have moderate asthma. But health professionals generally will classify asthma by how well controlled the symptoms are. So we talk about well controlled asthma, partially controlled asthma, and severe asthma, and it's all to do with how the symptoms present. So if you don't have any daytime or nighttime symptoms, or you only have them on sort of 2 or less days of the week, that would be well controlled. If you don't need to use your reliever inhaler very often at all, or less than 2 days a week, that's very well controlled. So it's really, and then partially controlled is sort of the 2 or more days of the week. And severe asthma or uncontrolled asthma is really where it's not well controlled at all. You're always having to use your reliever inhaler. Your asthma's waking you at night. You're having daytime symptoms where it's really severely impacting on your quality of life.
Yeah.
So you've spoken a little bit about the 2 different types of inhalers. Apart from the inhalers, is there any treatments for asthma?
Yeah, well, generally asthma treatment, it comes in an inhaled form, because that's sort of the most effective way to deliver microgram doses. So when you think about other medication that you may take, say for example antibiotics, you might have amoxicillin and you'll see it's 500 milligrams or 250 milligrams. When you're looking at inhaled medication, because it's being delivered via that inhaler device, you are talking micrograms. So it's very, very tiny doses of medication. But the most important thing with that inhaled medication, and this is the statistic, is that 80% of people don't have good inhaler technique. So they are actually receiving a suboptimal dose of that medication. Okay. So while it's a very small dose, it's extremely important. I mean, that the onus is on the health professional, so whether it's the doctor, the nurse, or the pharmacist, to teach good inhaler technique. And it's something that forms every single step of our consultation or when we're reviewing somebody, that we are constantly reviewing that inhaler technique. So yes, by and large, 99% of medication for asthma is delivered via an inhaler. There are occasions when you'll have an asthma flare. It might be, in conjunction with a season, or you've got a cold or a flu, and you may have to have oral prednisone. So that, and then we're looking at milligrams. So the recommended dose, 20 milligrams, 2 tablets for 5 days. So you're looking at, by and large, if you are using your inhalers correctly, and the inhalers, I probably should I think most people probably see people shaking up an inhaler. It's generally probably a blue inhaler that probably looks something like that inhaler there. That's not a good indication of asthma being well controlled. So the mainstay of asthma treatment is using a preventer inhaler. So preventer inhalers are very, very small doses of an anti-inflammatory or corticosteroid that are inhaled and used every single day. They treat the underlying cause of asthma, and that is inflammation. So it's making sure that that smooth muscle in those fine breathing tubes, the bronchioles, is not inflamed, that the lining is not swollen and narrowing, and that mucus production is under control. And that's what the steroid inhaler does. The thing is that it's a little bit like taking a multivitamin. You can't feel it working, but it's an insurance policy. It's it's working in advance. So you use it every day, generally morning and night, just depending on what your regime is and what type of asthma action plan, which I can talk about later, you're on. And then your reliever inhaler, which is that blue inhaler you see people grabbing out of their school bags or sports bags, that is just used when you have tightness in the chest or wheezing, or you may have developed a cough. The more you use that reliever inhaler, the more it is a sign that your asthma is actually not well controlled. And so then we would start looking at, well, are you using your preventer inhaler every day? It's remembering to use it, and often it's a twice daily dose. And so we tell people to put it with their toothbrush, because you're generally cleaning your teeth twice a day. Put it somewhere where you'll remember to use it. If your asthma is well controlled, you will very rarely ever need to use your reliever inhaler. So you have your preventer inhalers, that's your mainstay. You've got your reliever inhalers, which are generally very fast acting. They work in a matter of minutes. You have symptom controller inhalers, which is another type of medicine. So for people where the preventer's not controlling their asthma, you need to use a long-term reliever. So instead of it lasting, say, for 4 to 6 hours, it will last for 8 to 12 hours. And so you have to use your preventer inhaler, but you use this long-term reliever as well. And then, just to make it even more interesting, we have combination inhalers. And combination inhalers are really where the asthma treatment is at the moment. So that's a combination of both your preventer and your reliever all mixed up into one inhaler. With some of those combination inhalers, so it's a steroid and a reliever. A reliever inhaler is the thing that causes the bronchodilation, so it relaxes that smooth muscle in the airway so that you can breathe more freely. Some of those combination inhalers, if you have an asthma attack, you will still need to have that fast-acting short-term reliever inhaler on hand. Now, in the New Zealand asthma guidelines and the international guidelines, the recommendation is for a very specific type of combination inhaler. The actual mixture of the ingredients is a steroid called budesonide and a long-term reliever called formoterol. And at the moment in New Zealand, there's only one brand of that, and that is licensed. It's called Symbicort, and it comes in a tubuhaler. So it's not a shaky inhaler that's driven by an aerosol. It's actually a dry powder inhaler that you twist, and it loads a reservoir, and you suck that inhaler. Now that and formoterol, that ingredient in there, is very unique because it is actually a very quick onset. It works within just a few minutes, and it's very long acting. It can last for up to 8 hours or so. It can actually be just used now as a reliever. So where you see people just maybe using their Ventolin inhaler pre-exercise or in an asthma emergency, you can actually use that inhaler just as required. But you can also use it every day. So it's very unique.
Wow.
It is complex, just to sort of give you an idea of how many different types of inhaler devices. There are this many different types of devices.
Wow.
So, you know, it's not like you can sort of go to, you know, a pharmacy and say, well, look, I'd like that medicine and that inhaler. But the choice of inhaler, first and foremost, depends on which medication is appropriate for your asthma.
Yes.
Secondly, there's no point in giving you an inhaler if you can't use that device. So it has to fit. Then it is like, is it a once a day dose? Is it an as required dose? Is it a twice daily dose? So it then has to, it has to be the right medicine delivered in the right inhaler device, and it has to be appropriate for your stage and age in life, because there's no point in having it if you're not going to use it, or it's very difficult to use, or you're not using it correctly. And if you're not using an inhaler correctly, you're really going to end up with all of that inhaled medicine either in your mouth or your throat, which is going to give you a very sore mouth. And if it's a steroid, you could end up with, you know, oral thrush, which is very painful, which then needs to be treated. Or you could end up with a very croaky, awful voice, which is not something that, and if you have those side effects, then there's a tendency for people then to avoid using them.
Avoid using it, yeah.
Yeah. So sometimes we use different ways, like particularly with those metered dose inhalers. I don't know if you've ever seen kids using spacers. So this device here is called a spacer, and it's actually recommended now to use these for all ages. So if you have a metered dose aerosol inhaler, the mouthpiece will actually fit into the end of that. And you sort of can hear this thing shaking. There's a valve in there. So you shake your inhaler, you place the inhaler in that mouthpiece, and then your lips form a seal over that. And then you're able to just depress the inhaler and just breathe in that dose. And instead of having to have really good inhaler technique and coordinate the pressing of the inhaler and the holding of your breath, and of course, part of that inhaler technique is that you don't then, after you've held your breath, then deeply exhale through your mouth. You then gently breathe away through your nose. Otherwise, you're just going to force that dose of that inhaler out of you. But with the dry powdered inhalers, like the turbuhalers, you can't use a spacer. It's a dry powder. So it's but where you can, if you have an aerosol inhaler now for all ages, they recommend taking it because it actually increases the amount that's deposited into your lungs by 50%.
Wow.
So it's very significant. And, you know, so if you're young, if you're elderly, if you're any age, and particularly with administering that all-important preventer inhaler, the space is a very good tool.
Wow. It's really interesting to know, because you do see the different types of inhalers and things like that, but it's complex, but also not at the same time. And obviously, like, professionals will be able to give advice on that, so you're not making the choices yourself. But yeah, really interesting to know.
It's confusing even for health professionals, because I have to say, like, you know, over the years, if I've taken my kids to after hours, how many consult rooms have inhaler charts on their wall? And, you know, to give you an idea, like this is sort of one lot of inhalers, and here another lot of inhalers.
Wow.
It is actually extremely confusing. And it, you know, it's not unlike actually, you know, insulin management. That's also very confusing. So, and it changes, and it's not just the different types of inhalers and the different medicines and how they act. it's the funding of those medicines. So you may have some inhalers where you may have 2 strengths that are subsidised by pharmac and 1 strength that isn't. Or you may need a special authority to have a particular inhaler. So there's sort of funding issues around, and that's also really important from a patient perspective as well.
Yeah. Wow. We had a question come in, and it's kind of like we hear the term asthma attack, but what is an asthma attack and what causes it?
So an asthma attack, there's sort of different names for asthma attack. You can call it an asthma flare or a flare up or an asthma exacerbation. And it basically, it results from when you are unable to avoid those triggers that you have for your asthma. And I don't actually know if we've gone into those triggers yet, but it'll be where you haven't been able to avoid those triggers, or you've been exposed to the triggers that cause your asthma. It could be one trigger, it could be a number of triggers, or when your everyday treatment isn't controlling your asthma. So, you know, an asthma attack is actually a very, very serious and life-threatening condition. And it results from, again, the bronchioles, that smooth muscle in the bronchiole becoming contracted and tightened, from that lining inside the bronchioles becoming inflamed, and from that sort of increased mucus production. And it's terribly, terribly frightening for people. If you see someone having an asthma attack, they will probably be unable to speak. They will probably start to have bluish tinging around the lips. They're looking at their fingernails, you'll see that they may even be blue. They'll probably be struggle to move or walk. It would be like getting a straw and pinching a straw and then trying to breathe in. You just cannot breathe, and it's terribly, terribly frightening.
Yeah.
And so, you know, it's really, really important to empower people to recognise worsening asthma symptoms. And so anybody that has asthma should have a self-management plan. And a self-management plan is an action plan that you develop with your healthcare professional. So either your nurse prescriber or your doctor. There are different sort of regimes. So we're talking, depending on the regime that you're on, you'll have the Air Asthma Action Plan. That's that Symbicort medication I was telling you about earlier. 3-stage or 4-stage. When you open up that plan, you'll see it looks like this. And we operate on a sort of a traffic light symptom system. So the green is when it's all good. So all your symptoms are under control. That means it's an indication that your medication, your inhaler technique is good, that you're avoiding those triggers, and that your medication is working correctly. The most important thing with this is that to then recognise when your asthma symptoms are worsening, and when you start to migrate into that orange zone, which is that worsening sort of area, you will be really cognizant that you're having to use your reliever more often than normal. You'll be conscious that you're developing a persistent cough, that you're tight in the chest. In that plan, there'll be instructions for what you need to do. So it might be that you may be on the 4-stage plan where you actually can increase your dose of your preventer inhaler up. You may have been prescribed a course of prednisone from your doctor, and you may start that course of prednisone at that stage. So some people find that it's all about understanding what asthma is, understanding how your medicines work, and responding to those symptoms. So if you end up in a position where, despite everything, you end up in this emergency red section, then that is when you are having what we call an asthma emergency or an asthma attack, and that's serious. So at that point, you need to make a quick assessment, or the person caring for that person needs to make a quick assessment and decide whether it's if it's mild, or if that person has moderate or severe symptoms, or if they're frightened, you just don't hesitate. You ring 111 immediately. And while you are ringing that person, you're basically administering what we call asthma first aid. So you are, just like normal first aid, assessing it, the severity. You're sitting that person down, calming them down, reassuring them, removing any sort of tight clothing. You then start to, in fact, it actually follows the asthma sort of mnemonic, and then you will then start a treatment which will be their reliever. So depending on what type of reliever they have, whether it's that turbuhaler type of reliever or whether it's that fast-acting Ventolin type of reliever, if they have a spacer, that is the time to be using a spacer, especially when they're panicking and they're finding it difficult to breathe. So it is then administering, if it's a Symbicort, it's just one dose. So with your asthma action plan, you'll either have this in like a paper format, you might have it in a digital format, or you might have it as an app on your phone, because we have an amazing app called My Asthma app. So you will be prepared and you will learn to recognise those worsening symptoms. Some people like to keep a symptom diary, and they will actually every day write down how they felt that day, whether they needed to use their reliever, how many times they needed to use it, whether they were woken at night with asthma. Some people will even have a peak flow meter, and they will blow their peak expiratory flow. So it's like blowing out the maximum you can, and you have a reading that you record, and you will actually see from those readings, you graph it, and you'll almost be able to predetermine that your asthma is worsening. And then you will look at your asthma action plan for, so a lot of asthma attacks or asthma exacerbations can be prevented with very good self-management. But obviously when you have an asthma emergency, don't hesitate to call 111, because unfortunately the sobering statistic is that people in New Zealand do die from asthma, and it's a very sobering but real statistic. I think about 77 people a year die from asthma. So I don't think we think about that. I think that we're very complacent in New Zealand and very accepting of asthma, but it is actually a huge public health issue for us. And one in 7 children and 1 in 8 adults in New Zealand, 20% of the population have asthma.
Wow. So with asthma, is it something that can go away over time, or is it something that once you've been diagnosed with it, you know that you've got it, it stays with you for your life?
If you are a younger child and you are diagnosed with asthma, say as a preschool child, there is a chance that you won't go on to have asthma at school or as an adult. If you have been diagnosed with preschool asthma and say you have eczema, one of those sort of genetic, there is a chance that you may go on to have asthma, or if you have a parent that has asthma, then there is a likelihood that you will go on to have asthma. But generally, once you have it, it's a chronic long-term condition that can be really well controlled and well managed. If you have a self-management plan, and if you learn to avoid those triggers, and making sure that you have optimal dosing of your medication at all times. And that means that you're making sure that you're picking up your repeats, you're making sure that you're using that preventer inhaler every day, that you don't become complacent about your inhaler technique, that it changes with you as you change and migrate in your life. It might be that a once a day type of treatment is better suited to you. If you're rushed and it's not going to fit into your busy life. So we want patients to be having those close relationships with their health professionals. So whether it's their GP, whether it's their nurse prescriber, their asthma educator at an asthma society, their pharmacist, it's a constantly evolving plan, and it's a partnership. We don't want you to be prescribed inhalers and have your inhalers dispensed and then that's it.
Yeah.
And not be ever afraid to ask questions at all.
Yeah. We keep throwing around, I guess, the word triggers. So what kind of are the different triggers for asthma?
So with asthma, there are so many different triggers. Probably at this time of the year, it's more changes in temperature. So particularly cold temperatures, cold, dry climates. It's really important. I think we don't think about this, but when we breathe in cold air through our nose actually filters that cold air and it warms it and humidifies it so that we breathe in to our lungs. When you're a mouth breather or you breathe in cold air, that is different, can be a different trigger for asthma. So even if you are exercising or you're walking out at night in the cold temperature, make sure that you wear a scarf up around your nose and your mouth. A huge problem in New Zealand is obviously cold, damp homes. You know, mold spores are terrible triggers for asthma. It could be pollens. Like a lot of people find that their asthma is triggered particularly in the hay fever season, which is sort of October to March.
Yeah.
So, can be when you have a virus, an upper respiratory tract infection, like a cold or a flu, is a huge trigger for asthma. It could be particularly cats. So furry animals, it's not actually their fur, it's the dander, it's the sort of particulate, it's their saliva and the skin shedding from the animal. So, you know, things like your choice of pet, or if you have an asthmatic in the household, it might be, do you let that pet sleep in the bedroom? It can be making sure that, you know, you use a vacuum cleaner that has a HEPA filter. It's actually really, I think some people go overboard and they think that they decide what their triggers are, and decide they're going to, you know, polish all their floorboards, and that may not be your trigger, you know, dust mites. And so it's really identifying and learning to recognize what your trigger is, and then avoiding that trigger. I mean, obviously not going to be able to avoid when you get a cold or a flu, but there are some things you can avoid. And so allergen avoidance is obviously the best method to not trigger asthma.
So you had mentioned earlier about people's asthma, that it could be worse at nighttime or in the morning. Is there a reason for that?
It's there's lots of different theories for that. The nocturnal cough, particularly, I used to find as a pharmacist, people that would come in and buy cough and cold syrups, and you'd start going through this sort of differential diagnosis about the symptoms, would always alert me to, and then asking about a family history of asthma. But it can be a little bit like what we talked about before. It might be that the house is cold and damp. So it's really important that that bedroom temperature is maintained at about 20 degrees, believe it or not. So having a constant warm temperature in the bedroom, making sure that maybe the pet isn't sleeping on your bed, or this pet hasn't been sleeping on the bed, making sure that you are regularly washing and airing pillows, duvets, blankets. Some say that it's due to a release of a hormone called cortisol at night, which can trigger inflammatory reaction in the bronchioles. Some people find that when they lie down, if they have had a big meal or they're predisposed to having sort of gastric reflux, there is a condition called GORD, which is gastroesophageal reflux disease. And when you lie down, that valve, that sphincter, can sort of leak your gastric secretions, and that can cause inflammation in the airways. But generally it's probably more to do with temperature, but also just the conditions in your bedroom. So just being really sensible. There are actually so many practical things that you can do to prevent asthma. You know, obviously washing bedclothes. You can get special allergen-free covers that can go on your pillows, on your bedclothes. So, yeah, but a nighttime cough or an early morning cough, maybe that during hay fever season, or you're sleeping with your window open, or it could be a windy day and you've got pollen flying around. And that's why keeping a symptom diary is so useful, because you'll generally find a pattern, and then you can identify that trigger.
Another question that kind of came in a bit more specific, and it was around, we just kind of mentioned earlier about exercise-induced asthma, and someone had said that they found that they would do intense exercise and then that flare up their asthma, and the question was, what can they do about that?
Yeah, probably the most important thing to say is that don't avoid exercise. Like, it is really important for everyone, but even probably more so for asthmatics, to get the blood flowing, to increase your lung capacity. You'll generally find with asthmatics that the stop-start type of activities are good for asthma. So things where you, not necessarily yoga and things like that, but say something like walking, swimming, anything where you can stop and start it. Things like, say, cycling and running, sort of high intensity events, is two things. One, you need to make sure that you warm up prior to any exercise if you're an asthmatic. And two, if you are an asthmatic and you know that you have exercise-induced asthma, you will need to use your reliever inhaler prior to exercising. Now, you also may need to use that reliever inhaler during the event as well. And if you do, that to me is an indication that perhaps your asthma is not so well controlled. And so when you see people with their Ventolin inhalers sort of having a couple of puffs pre an event and maybe during an event, that is something that I would definitely be discussing with your doctor or healthcare professional, because that's where you may need to have that combined type of therapy where you are also taking on board a dose of an anti-inflammatory as well. Because remember, it's not just dilating the bronchioles and getting those airways open, it's treating the underlying cause, which is inflammation.
Yeah.
One more question for you. So who do you go and see if you think that you might have asthma, or if you are worried that your normal treatment plan for asthma is not working?
Okay, Doc, that's a very, very good question. So obviously, if you have a GP, your general practitioner is probably most people's first port of call. If you think that you have asthma, if you think you have those telltale signs, and wheezing is obviously probably the most characteristic sign, but that coughing, that persistent cough that's worse morning and night, that wheezing, that chest tightness or that breathlessness, it would be helpful to even keep a little diary about when you're having those symptoms. So are you coughing more at night, more in the morning? Are those symptoms exacerbated or brought on at certain times of the year or times of the day? So generally it would be your general practitioner. It could be you may have a nurse prescriber or a pharmacist prescriber. But if you spoke to any health professional, whether it's a pharmacist or a nurse, they will be able to direct you to the right person. It might be, and definitely at that point, your doctor or nurse prescriber or pharmacist prescriber will be able to do a clinical assessment. So look at those sort of 4 key symptoms, look at that characteristic pattern of those symptoms. Yep. They'll get you to probably blow into a peak flow meter, and it isn't, and then they'll probably start you on a trial of asthma therapy. And if you are an asthmatic and you feel that you're losing control of your asthma or it's worsening, for most health professionals, the first thing that they would do is just check that inhaler technique all the time. It's not meant to sound, the reality is that we do become very complacent with the way that we inhale things, and we forget the steps. And a common one is using an inhaler and then forcefully breathing out through our mouth afterwards. So it's just making sure that you're remembering to use it. That is, the most common thing. And as a pharmacist, most inhaler medication is monthly dispensing. And so, of course, you're looking at someone's medication history, and you'll say to them, "Oh, you'll be due to have your Flixitide inhaler." No, I don't need that. I've still got that. You think you haven't picked up your Flixitide inhaler for 4 months. There is just no way that you can have run out of that. There's 120 doses in there. I know that you're using 1 inhaler per month if you are using the correct dose. And so just emphasizing to people, it's health literacy. It is not the patient's fault. It's actually the health professional's fault for maybe not ensuring that people understand how the medication works, or understanding their condition, understanding the triggers. But yeah, if you don't feel that your medicine is working, the easiest thing is probably to talk to your pharmacist, because you're probably going there every month. And they can definitely go through your inhaler technique, just check the dosing. If your dosing is your inhaler technique's perfect, and we're pretty sure that you're actually inhaling an optimal dose, then we would definitely be referring you to the doctor or your nurse prescriber. Asthma societies are most of us probably don't even know that asthma societies exist, but there are respiratory nurses and asthma educators that just specialize in asthma and COPD, and that's really your first port of call for asthma education. It's a free service. They spend time with you, unlike where it's difficult to get into a doctor.
Doctors,
and you'll generally find that if you, at most medical practices, general practices, that there'll be an asthma nurse champion, or in a pharmacy, there'll be a pharmacist nurse champion. There'll be someone that will go, "Oh, we'll get you to speak to Joanna," and there'll be someone there who is just a go-to, that will just sit down and give you that time that you need to go through and understand your medication.
Awesome. A final question that we've been asking every speaker so far this series is, what is one thing that you would like young people to take away from this conversation tonight?
For me, it would be, don't be complacent about asthma. In New Zealand, asthma is a huge public health issue. It's huge, and our Māori and Pacific people are really overrepresented in statistics. And when you look at the stats for DHBs and ethnicities and age, it's very, very sad reading. Often, it's those same people too that are admitted to hospital or go to the A&E only to be sort of discharged back out into the community and be, around cigarette smoking or in a cold, damp home, or it's just the same triggers. So with, 20% of our population having asthma, I want people to really take it seriously. People do die from asthma. The most important thing is make sure you are using your preventer inhaler. If you are using your preventer inhaler and your asthma is well controlled, it will not affect your life at all. You will, it will have very, very little impact on your daily activity.
Yeah. Awesome. Well, thank you so much for being with us tonight.
It's my pleasure.
It has been so educational to hear about all of this, because sometimes you just don't, sometimes you do see a GP and it's like 15 minutes and, that's it. And so you don't get all this information. So it's been really good to chat with you tonight. Thank you so much to all of you that joined us on the live stream. We loved having you there. Our next episode of YAC Yarns is next week, and actually we can announce that we're with Asthma and Respiratory Foundation New Zealand again, but we'll be talking about vaping next week. So thank you so much for joining us, Joanna. Thanks all for joining us on the live stream, and we'll see you again next week.
Thank you. See you.